A very good evening, friends. I take this opportunity to welcome you all, and we will start immediately because Professor Kaul is also joined, and it is a good fortune to have such a senior person, one of the finest and the senior most respected authority who has come as our chief guest. And I would request, Namaste sir.
Hello. Good. Very nice seeing you. Nice seeing all of you.
Yes, sir.
Yes, sir. Good evening, sir.
So we wish you would have been at this wine city of the wine capital of India, but we'll make it up. So Milan, please start. He has some obligations, and let him start with the presentation, and then we come with the welcome speech and everything. Yes.
Can you just check let me share the screen.
Yes, sir.
Yes, sir. You please share.
Okay.
So,
can you see it?
Yes, sir.
Yes. So it's my proud privilege to be with all of you. Just a minute.
Sir, आपको पहले वो खाली आप देख के फिर पहले we have to have that lamp lighting and all, and then after your introduction.
Okay, chalo.
Yeah.
Vinod sir, I'll just straight away start with this lamp lighting if you permit, because we'll skip the corporate part.
No problem. You take your time. No problem.
I will request now, since everything is digital, this is a very unique experience for us, and we will request Professor Kaul to digitally inaugurate. So we have kept two flames. One will be lit by the chief guest, and the second flame by all of us. Please, let's have the lamp lighting. Professor Kaul has lit the lamp. Very good. And this is on behalf of all of us, by all of us. Now we invoke the goddess Saraswati before we start our program. So Saraswati Vandan, please.
Yes, sir.
So we'll just follow the protocol, and then before we start the program, we always. And after having invoked the goddess Saraswati, it is our national duty whenever we start any program, especially ours being the installation ceremony of our new society. And before I introduce, is to start with the Rashtriya Dwaj, national anthem. This is to pay a tribute to our nation and all the doctors who have really, and many of them have even sacrificed their life in this pandemic. I would request you all even to please stand while the anthem is being played.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल गंगा विंध्य हिमाचल यमुना गंगा उज्जल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगल जय 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 हे
Bharat Mata ki Jai. Sir, I would then start with the introduction and share introduction. Yeah. So friends, it's my pleasure to mention about the society because we all have to know this is the beginning of a new era in cardiovascular associations and of services in Nashik region and beyond by the specialists themselves. Today on the 9th of Jan 2022, unfortunately by compulsion of circumstances, it's a digital affair and we had no choice. It started much earlier. Even when we used to have our API meetings, I remember at our farmhouse when Professor Nanda he had come about 3 years back. We cardiologists yet formed a subgroup in that, and we were discussing like how can we form our own society. And this is one of the picture which is about more than 3 years back. And even you can see among all 118 physicians who had come, the cardiologists, wanted to form a subgroup. And it started again, sometime the first meeting, I think we do not have the pictures, was Dr. Manoj Chopra had invited all the cardiologists to his house for a wonderful breakfast. And we'll get the pictures and add it. And then before we formed the society officially, Dr. Dharmadikari at his estates and branch had invited all of us. And then we had a meeting and we were planning that something should be done. We have to come together. Finally, it happened. And look, today it happened on the 10th of Jan. That is almost 1 year because tomorrow it will be 1 year. This was again at my farmhouse where we all met and we decided that we must form a society. And then we have our Amit Shah and Aditya Nath, that is Manoj Chopra and Dharmadikari who proposed that being the senior most person, I should take over the society. And then I obliged. And today we are seeing the light of the day. And this was the meeting there. And we really started working on it. This was the cake, cardiovascular forum, which we cut. Today, of course, we have another physician who's there, cardiologist who is with us. His birthday, wishing him a happy birthday, Dr. Praveen Jadhav. And we had our first executive body meet. Executive body, we had kept it open. Those who want to come and join, please come voluntarily, you'll have to work for it. And this was at Emerald Park in August. We wanted to discuss about registration process, the criteria, bylaws, documents on starting the activities, PAN card, GST, bank account, MMC registration, appointing a CA, website development and registration. And it was a big job. And yet we took it, and many, those of us who volunteered, and of course, the secretary was a person who was willing or unwilling, Dr. Vikrant, because he had no choice. Being son, he had to help his father. So, and then I remember when I was told by Mr. Upendhra that we have to go to Charity Commissioner's office and he will take your interview and afterwards he will decide whether you have to be given the Charity Commissioner certificate. When I went, it was only one meeting. He made me wait for half an hour. I was wondering why. And he handed me the certificate in hand, which was shocking and surprising to all, knowing the type of work which we were doing. So this is the Charity Commissioner who was the magistrate. He handed it over immediately. That was one of the fastest registration we ever knew. Shows all our genuine interest. We then applied to the income tax authorities. We got our PAN card. We got our bank account. So friends, this cardiovascular society in Nashik is unique and probably it is the only one maybe in the country which is an association of cardiologists, cardiovascular surgeons, vascular surgeons, interventional radiologists. 4 pillars we have formed, and Professor Kaul will also agree with that. I don't think there is any society like this. Sir, may I make it very clear that we are not any rebel society or to make a parallel to CSI. We had communications with all the presidents of CSI for the last 5 years, and we were told that they have stopped forming CSI various chapters since last 5 years, unless it is a new state. And that is why we decided, why not take it to our advantage, and we take the whole people, the gamut of surgeons, and that is how this is a very unique society, which we had already met. I had shown you the pictures. This forum would forge kinship amongst cardiovascular specialists and take academics and patient care to greater heights than never before. So it is already registered as a trust. The core focus of the society would be academic and advancement, regular CMEs. We have already had one, clinical meetings, workshops, annual refresher course, co-share technologies, like many of the youngsters may not have access to a rotablader and all, make it open to all, and similar technologies, so that we all can give it the best to our patients, collect even epidemiological evidence of disease pattern which is specific to our region, jointly conduct clinical trials, and we are very fortunate to have, I should say, the father of clinical research in India, Professor Kaul, sir is there with us. He will mention standardized treatment protocols, enhance the image of cardiovascular society and our society in the public, periodically even conduct camps and enhance kinship amongst fellow colleagues and their families, and even organize family functions and get-togethers. And sir, today we were to actually meet with all the spouses and the doctors and the better halves, but unfortunately, because our booking is still there today, but it has been cancelled because of the COVID. And even pursue the idea of group insurance for members. So we started even scouting for the inaugural value. Many of us took time out from the practice. We were there at TTC Rest House, and even this is Radisson Blue. And then the first official warm-up meeting was at Gateway Taj, which was on December 21st. And then we decided that we will be holding the meeting, come what may, digital or physical or non-physical. So today is non-physical. The warm-up was physical, and you can see here that shows the enthusiasm among all those who could attend. So even we have already started making our, even like the protest, where in New Delhi, many young doctors were demanding to expedite NEET entrance. They were beaten up. The society put a protest in our national forums that we stand by our national IMA, AMC and all, and for our doctors. So friends, now it's my pleasure, it's an honor to welcome Dr. Upendhra Kaul. We have got chairpersons. We have got Dr. Abhay Singh Walia. I hope they are admitted, and they will be introducing Professor Kaul, Dr. Anirudh Dharmadhikari and Dr. Manoj Chopra. They will take over the meeting and to its conclusion, and then we come back for the inaugural ceremony. Please, Dr. Anirudh Dharmadhikari, Dr. Manoj Chopra and Dr. Abhay Singh Walia, you are all there, I suppose. Please come and take over. Sir has given one slide. He said just put only one slide, but then I thought let us, yeah, please take over. Is Dr. Abhay Singh Walia there? Dr. Walia is there? Dr. Anirudh Dharmadhikari? Dr. Manoj Chopra?
I think. Yeah, I am there.
Manoj, yes.
I welcome Dr. Upendhra Kaul as a guest speaker for this important event of formation of a cardiovascular society. As Vinod said, it's last 3 years we were discussing it, but now today is the day where it's been formed and all government formalities has been completed. To introduce our speaker, Dr. Upendhra Kaul, I think we all know him. He doesn't need an introduction, but just a formality, I'll say that he's credited with starting the coronary angioplasty program in India. He's editor-in-chief for Asia Interventions, associate editor, Euro Intervention, and he's course director, AICT Asia, PCR, and India Live. And he's the recipient of numerous awards, including Dr. B.C. Roy Award, and Padmashri from President of India. At present, he is Chairman, Batra Art Center, Dean Academics and Research, New Delhi. Basically, we all know him for his clinical acumen, his enthusiasm for teaching all young cardiologists, and he is involved in a lot of research work. I welcome him and I ask him to start his talk.
Thank you very much. It's my proud privilege to be at this very important meeting of the Cardiovascular Society of NASIK, which is representing the cardiologists, cardiovascular surgeons, the interventional radiologists, and vascular surgeons. I think it's a unique, broad-based society, and it's my pleasure to be with you. And I basically thought that I would apprise all my friends of some important clinical trials of the year 2021, which are very important and are tipped to change the practice patterns in cardiology. So let me start by sharing my slides. So let me start with this particular trial, which I think is one of the most important trials of the year, because we know that for heart failure with preserved ejection fraction, there was no specific drug. ARNI also failed in the Paragon study. So we were, at a loss how to treat these sick patients. Today, we also know that the heart failure has a universal definition now. And all of you must know this definition. It has been ratified by all the societies of heart failure. Patients who have a left ventricular ejection fraction, which is less than 40% or 40%, is called heart failure with reduced ejection fraction, the common garden heart failure, which we see with low ejection fraction. Patients with 50% or more than 50% ejection fraction are the patients with preserved ejection fraction, heart failure with preserved ejection fraction. And in between the two is 41 to 49% patients with heart failure with this ejection fraction are called heart failure with mildly reduced ejection fraction. Previously, some people used to call it heart failure with mid-range ejection fraction, but today it is called as mildly reduced ejection fraction. And a fourth category has been included because we have therapies to improve the ejection fraction, and that is heart failure with improved ejection fraction. These are the patients who at the baseline had a heart failure with low ejection fraction, less than 40%, and over a period of time, spontaneously or because of the aggressive guideline-based medical therapy, have improved their ejection fraction by more than 10% and have come to the normal ejection fraction range. They're called heart failure with improved ejection fraction. Now, coming to heart failure with preserved ejection fraction, it is a large chunk of the patients with heart failure, and it seems to be constantly increasing with the diagnostic facilities improving. As you can see in this slide, between 1985 to 2014, heart failure with ejection fraction, preserved ejection fraction has improved, has increased from 41% to about 50-55% jump. We also know that whether the patient has heart failure with reduced ejection fraction or with preserved ejection fraction, the 1-year mortality and the 5-year mortality is nearly the same. So that would mean that there is no reason to become complacent in a patient with heart failure who has all the features of heart failure, but with a normal ejection fraction, because their mortality is the same as with the low ejection fraction. And hospitalization is one of the biggest problems with patients with heart failure, and also the quality of life. So as you can see, hospitalization has the greatest impact on the quality of life. Any person with heart failure who gets repeatedly admitted, it is very demoralizing for the patient, for the physician or the cardiologist, for the family, and for everybody. Again, he has got admitted. And with every readmission, the general condition of the patient worsens. We also know that. Hospitalization cost, approximately 80% of the cost of the hospitalization. 80% of the cost of the treatment of heart failure is because of hospitalization. You know that hospitalization, whether it is in a superstar, five-star hospital or in a smaller hospital, is expensive because of several things. You know, drugs, patients commuting, patients losing their job, patients' family members having to take leaves. So it all is a very, very expensive proposition. And the proportion of patients who are hospitalized with preserved ejection fraction is projected to increase over the years. Now, what was the standard treatment for the patients with heart failure? And this is, the class 1 indication. First of all, patients with heart failure with preserved ejection fraction, we need to find out the etiology and treat the associated conditions like hypertension, coronary artery disease, or non-cardiovascular comorbidities. And then the only therapy which we had was diuretics because they're congested, and give them diuretics. But we know that diuretics do not improve the outcomes in heart failure with preserved ejection fraction. A spironolactone in the TOPCAT study showed some improvement, but then it was not statistically significant, and that also in a retrospective database of a small group of patients. So there are no treatments indicated which are guideline based by which we can say that give this and the patient will improve. And if we see the heart failure preserved ejection fraction in our Indian scenario, you would see that the in-hospital mortality, 30 days, 90 days, up to 3 years, it goes on increasing. This is from the very well-known Trivandrum heart failure registry. And patients who have readmission with preserved ejection fraction, their mortality, again, here it also says it is identical. Whereas patients with reduced ejection fraction or preserved ejection fraction, if they have no readmissions, their mortality is substantially reduced. So any therapy in heart failure with preserved ejection fraction, if we can significantly reduce the admissions, it is a big boon. Now, SGLT2 blockers, as you know, have come up as a very important tool. We have two of them available, dapagliflozin and empagliflozin. Now, empagliflozin trial, the Emperor Preserved, which I'm going to present, has already been presented, whereas the trial with dapagliflozin is still going on, and we don't know what the results will be. And in science, one does not predict the results. Now, the cascade of mechanisms why empagliflozin may be working favorably in the patient with heart failure preserved ejection fraction is that it reduces the oxidative stress, it reduces inflammation, it reduces stiffness of the myocardium, it reduces hypertrophy, and it also reduces the extracellular matrix remodeling. So these are some of the mechanisms. And a number of studies with empagliflozin have gone on. We know that EMPA-REG, which was a study for diabetes, it showed that there was an improvement. First time any drug which improved the outcomes in diabetics was empagliflozin in the EMPA-REG study, which came in 2015. Now, coming to this particular trial, the Emperor Preserved is a phase 3 study in patients with heart failure with preserved ejection fraction. And the definition they had taken is left ventricular ejection fraction more than 40%, because this new definition came later, although they have then dissected the data for the patients between 40 and 50 and more than 50 also. And they were given all the treatments which the patient needed in both arms, because it's a placebo-controlled study. One arm received empagliflozin in the dose of 10 milligrams, and one arm a matching placebo, and they were followed up for 26 months. The composite primary endpoint being time to the first event of adjudicated mortality or hospitalization. And there were some confirmatory key secondary endpoints, and they were first and recurrent adjudicated hospitalization for heart failure. And also, as we know, that renal dysfunction is an important component of heart failure, whether the eGFR over a period of time remains the same or improves. The inclusion criteria: ejection fraction more than 40%, symptomatic patients, They also took NT-proBNP, and more than 300 in patients without atrial fibrillation, and more than 900 if it was ejection fraction was, if NT-proBNP was more than 900. Structural changes in the heart, and there were some exclusion criteria like acute MI patients who have had a bypass surgery in the recent past because they could have improved otherwise also. Patients who have had a heart transplant, severe hypertension or severe hypotension, and very low EGFR. Patients with EGFR less than 20, that means stage 5 chronic kidney disease, were excluded. And the primary endpoint, as already mentioned, was adjudicated cardiovascular death or heart failure. And the secondary endpoint was recurrent hospitalization for heart failure. And also EGFR slope was looked at. As you can see, this is a large study, about 6,000 patients, and age around 70 years. Women about 45%. Asians constituted about 14%. And regions, once again, Asia around 12% of the patients. North America and Latin America about 37%, and Europe about 45% of patients. NYHA class, as you can see, 80% of the patients in both the arms were class 2, and about 20%, 18 to 20% were in class 3. Very few patients in class 4. Most of them were overweight. Blood pressure was stable. Ejection fractions were normal, average of about 50-55%. And 40 to 50, 33%, 50 to 60, 34%, and more than 60%, 30%. Please, 1/3 of them had less than 50, 1/3 had 50 to 60, and 1/3 had more than 60. Etiology of heart failure, non-ischemic heart disease, 64%, ischemic heart disease about 1/3. Hospitalization for heart failure in the previous 12 months, 1/4 of them. About half of them were diabetics, and about 90% of them were hypertensives. Atrial fibrillation, which is a very common accompaniment of heart failure, was present in about half of these patients. Now, these patients were already on RAS inhibitors with or without ARNI in about 80%, aldactone, spironolactone-like drugs in about 1/3 of patients, 85% were on beta blockers, 10% were on digitalis, 45% on aspirin because many of them had ischemic heart disease, and about 70% on statins. EGFR less than 60 was present in about 50% of patients. The efficacy outcomes, you clearly see that there's a 20% relative risk reduction in the primary endpoint. And the first time any drug has shown such a significant reduction in the primary endpoint of 20%. That means there was a 20% reduction in rehospitalization and mortality combined. And if you can look at, this was a confirmatory primary endpoint. And this was irrespective of age, sex, race, religion. Baseline ejection fraction where it was less than 50 or between 50 and 60, there was a benefit. Diabetics, non-diabetics, EGFR more than 60, less than 60, baseline NYHA class, not related. Hospitalization in previous 12 months did not matter. They all responded. And whether it was a ischemic disease or non-ischemic disease as the etiology, it worked in both. Baseline NT-proBNP, baseline body mass index, baseline use of ACE inhibitors, baseline use of aldactone-like drugs did not matter. And if you look at the secondary endpoint of hospitalization for heart failure, you see that there's again a 27% reduction in the group of patients who were on empagliflozin. So the secondary endpoint is also confirmed. Coming to the EGFR slope, you can see that in the beginning, the EGFR went down, which is known with most of the SGLT2 inhibitor. But over 100 weeks, you see there's a crossover, And at the end, there's an improvement in the eGFR, that means the glomerular filtration rate improved. So all the three endpoints confirmed. So Emperor Preserved clearly showed that it was a very clear benefit, although there was no significant difference in the mortality, but there was a very significant difference in the hospitalization for heart failure. And it was a combined endpoint of hospitalization for heart failure and cardiovascular death. In short, the drug worked by reducing hospitalization for heart failure, not the mortality. Other specified endpoints were the same. Safety outcomes, it was as safe as the placebo. The adverse events, serious adverse events, hypotension, renal failure, bone fractures, which have been, incriminated with some of the drugs like canagliflozin, they were identical. And UTI, which one is scared of using SGLT2 inhibitors in UTI, there was no difference, no significant difference. Bone fractures, no difference. So it was absolutely safe. Causes of death, you can see that cardiovascular cause of death, same. Stroke, same. Infections, same. So it was very safe, but at the same time, very efficacious in reducing the hospitalization for heart failure. In summary, I would like to say that half of all the heart failure patients today have heart failure with reduced ejection, or with the preserved ejection fraction. Emperor Preserved is the first trial in the history of clinical trials in heart failure with preserved ejection fraction, which has shown a beneficial outcome by reducing the risk of hospitalization for heart failure or cardiovascular death. There was a clinically meaningful 21% relative risk reduction in the primary endpoint. It benefited the kidneys. It improved the eGFR. So combining with Emperor reduced empagliflozin, it becomes one of the first therapies to show that it improves the cardiorenal outcomes, that it improves the, one of the very important endpoints of patients with heart failure preserved ejection fraction, that is hospitalization. So what I will do, I will go to the other trials, and then we will have questions on all, or if you want to have first questions on Emperor Preserved, most welcome. I would stop sharing.
I think you continue with your second trial. We'll have questions at the end.
Okay. So now I come to other 7 trials. First of this is the adaptable study, which was published as early, as late as May last year. This is comparative effectiveness of aspirin dosing in cardiovascular disease. We know that aspirin is very good for the prevention of, secondary prevention. We all give it. But what is the dose, which is the best dose? There is no large study on that. Some people give 150, some people give 320, some people give 75. And this is the first large study to show what is the maximum efficacious dose at the same time with minimum bleeding. What happened? Not able to change it. Okay, so this is the study design, an open label pragmatic design. The primary effectiveness being a composite of death from any cause, hospitalization of myocardial infarction, or hospitalization for stroke, which is assessed as a time to event analysis, and also the primary safety outcome, major bleeding, which was also assessed. A total of 15,000 patients, that's why I said it's one of the largest study, have been followed up for more than 2 years. Before randomization, about 96% of these had previous use of aspirin. 85% of these patients are previously taking a high dose of aspirin. And as you can see, both in the aspirin as the placebo group, there was high dose versus low dose. There's baseline variables are same. And this is the primary outcome. You can see the death hospitalization for myocardial infarction, or hospitalization for any other vascular events, the lines are parallel up to 42 months, indicating that the low dose aspirin, which was 81 milligram, as you know, Bayer sells aspirin as 81, and I think very often we use 75, that should be equivalent, is equivalent to a higher dose of aspirin. Major bleeding, you could see once again, it was in difference. After 24 months, the lower dose had some benefit. And 81 versus 325 milligram, as you can see, they're absolutely equivalent. So the study concludes that a strategy of 81 milligrams of daily aspirin had similar effectiveness as a strategy of 325 milligrams in patients with established ischemic heart disease, and the long-term adherence was much better, as one can always, logically say that lower dose will be tolerated better than the higher dose. Coming to another very important study is aspirin versus clopidogrel for chronic maintenance monotherapy after PCI. And this is the host exam study, a Korean study, but very important. We know that after our angioplasty, we give patients dual antiplatelet therapy. But after some time, we switch over to single antiplatelet therapy. Many of us after 1 year, some of us after 6 months, in high bleeding risk, sometimes after 3 months. But what do we give? Most of us give aspirin. This study has compared if we continue clopidogrel rather than aspirin, what happens? This aim of the study is comparison of head-to-head efficacy and safety of aspirin and clopidogrel monotherapy in this population for chronic maintenance antiplatelet therapy in patients who have undergone coronary stenting. Now, this is an investigator-initiated study, 37 centers, patients more than 20 years. All of them had PCI with a drug-eluting stent, and patients with any ischemic or major bleeding complication were excluded. And 98% of the patients were randomly assigned to either clopidogrel or aspirin, and aspirin in the lower dose. Assessment of the primary endpoint was completed in 98%. That means a very nicely, rigorously followed up trial. And what was the primary endpoint? Primary endpoint was a composite of all-cause death, non-fatal myocardial infarction, stroke, readmission due to acute coronary syndrome, and also bleeding according to the well-known Bach bleeding score, type 3 or greater, that means major bleeds. As you can see, the baseline variables were the same, and you can see that all the way clopidogrel was the winner. We'll come to this primary composite endpoint, 5.7 versus 7.2% benefit with clopidogrel. Bleeding, not different. Bleeding, if at all, aspirin had higher, clopidogrel had lower. All-cause death, once again, not very different, but non-cardiac death, again, not very different. Strokes, lower with clopidogrel. And any revascularization, not very different. Stent thrombosis, not very different. So during the 24 months follow-up, the primary outcome occurred in 5.7% in the patients who were on clopidogrel, single antiplatelet therapy, versus aspirin, single antiplatelet therapy. And this difference was highly statistically significant, favoring clopidogrel rather than aspirin. And as you can see, the primary endpoint starts within 6 months. You can see that clopidogrel is showing better. A composite of all-cause death, non-fatal MI, stroke, repeat angioplasty, acute coronary syndrome, or bleeding, all favoring clopidogrel. Cumulative incidence of bleeding, one can again see that after 9 months, bleeding is more with aspirin, not with clopidogrel. So the study says at the end, clopidogrel monotherapy compared with aspirin monotherapy for chronic maintenance therapy significantly reduces the risk of composite of all-cause death, non-fatal MI, stroke, readmissions with a lower bleeding. So this is again, I think, an important study. Coming to another important study with a drug which is so frequently used, and that is chlorthalidone for hypertension in advanced chronic kidney disease. We know that we see patients with advanced chronic kidney disease where the eGFR is between 19 and 30, and their hypertension at times becomes very difficult to control. You go on adding amlodipine, you go on adding, furosemide or other diuretics. What about this? Little evidence has been available to suppose that use of thiazide diuretics to treat hypertension at this stage in the patients with advanced chronic kidney disease. We never give it. We say it will be useless. And see, is it 160 patients with stage 4 CKD, that means eGFR 15 to 29, with poorly controlled hypertension, randomized to receive either chlorthalidone, starting from 12.5 to 50, and most of them received up to 25 only, which is the usual dose which we also use. And the primary outcome was a change in 24 hours ambulatory systolic blood pressure from baseline to 12 weeks. And secondary outcomes were the changes from the baseline to 12 weeks in urine albumin to creatinine ratio, that means renal function, what happens to NT-proBNP, and what happens to renin and aldosterone levels and total body volume. Safety was also assessed. And baseline characteristics, as you can see in this busy slide, are equivalent. Average age is 66, about 77% patients are males, and they have all kinds of comorbidities, with 3/4 having diabetes. And as you can see, the estimated eGFR is low in both the groups, around 23%. NT-proBNP is high, median plasma renin equivalent, median plasma aldosterone levels equivalent, median urine sodium excretion almost equivalent, indicating that they're matched. And as you can see, the blood pressure control, as you can see, within few weeks is much better when you add chlorthalidone to whatever the person was getting additionally. Once chlorthalidone was started in this trial, nothing else was allowed to be added, because then it could be something else. So, but you can see that chlorthalidone has improved the blood pressure control and maintained the body weight. 24 hours blood pressure, as you can see, there's an 11 millimeter reduction with chlorthalidone versus none with placebo. Nighttime, daytime blood pressure, both significantly reduced by more than 10 millimeters of mercury, which I think is a very, very significant improvement. And this tells us that we still can use thiazide, especially the very long-acting drug like chlorthalidone in these patients. Adverse events, identical. It did not increase any adversity. So over the course of follow-up for up to 3 years, after 2 weeks, the blood pressure continued to be controlled better because the volume of the blood had been reduced. And this is very interesting that you give it for 2 weeks. After that, even if you stop it, the blood pressure control is better. And some of them did undergo dialysis because they're all very sick patients, but then that was the very, very important. So the conclusion is that among patients with advanced chronic kidney disease and poorly controlled hypertension, chlorthalidone therapy improved blood pressure control at 12 weeks as compared to placebo. I think this again is an important message. Coming to FFR, we all do FFR, fractional flow reserve, in patients undergoing angioplasty. And this is very important. This is in the patients of ST elevation myocardial infarction who have multivessel disease. After the culprit vessel angioplasty, there are other vessels. Now the study is, if we do an FFR in these patients, does it help more than just by our eyeballing, what we see by our eyes? So this is the background, because this is an unresolved issue and we need complete revascularization. We also know that in multivessel disease, complete revascularization improves the outcomes as compared to partial revascularization. So basically, whether complete revascularization that is guided by FFR is superior to angiographically guided, this is not very clear. Smaller studies have been showing, variable results. Multicenter study, and the primary outcome was a composite of death from MI, non-fatal MI, or unplanned hospitalization leading to urgent revascularization up to 1 year. 500, you can see about 1,100 patients under randomization. And baseline variables, whether it was FFR based or angiography based, was similar. 60 years was the average age, and multiple risk factors, they were identical. That means the patient population, whether they were undergoing FFR or only anything. I think others should mute. So the primary outcome, as you can see, FFR guided versus angiography guided, no difference. Whether it is death, non-fatal infarction, secondary outcomes like stent thrombosis, hospitalization for heart failure. This is important, as you can see in these Kaplan-Meier curves also. Angiographically guided PCI versus FFR guided PCI hazard ratio is 1.32, no difference at all. So this concludes that in patients with ST elevation MI undergoing complete revascularization, an FFR guided strategy did not significantly benefit over an angiographic guided strategy with respect to any of the combined endpoints like death, myocardial infarction, or urgent revascularization. However, there's a limitation that given the wide confidence intervals, maybe we need more data on this. There was a very important editorial on Flower MI study. In the editorial, the expert says that any additional updates of treatment guidelines for patients with ST elevation MI will need to reflect evidence from all other available trials and should provide a class 1 recommendation whether angiographically guided PCI of non-culprit lesions in patients with ST elevation MI and stable multivessel disease is good enough. The results of Flower MI and the previous trial and the considerable cost of FFR guided PCI suggest that FFR currently has no role in guiding PCI in these patients. This again is a very important message in multivessel PCI. Believe your eyes more than going in for FFR. It's not adding to anything, it's adding to a time. It is not reducing the number of stents used, it's not reducing the amount of dye used, it's not doing anything good. Then coming to another important study. Colchicine in a low dose has been shown to be beneficial in acute MI patients in a trial. But this is in chronic coronary artery disease, which we see day in and day out. Its role in chronic ischemic heart disease is not clear. And this is a study which has been acronymed as LODOCO2, was executed for this. A large study, more than 5,000 patients with chronic coronary artery disease were randomized to receive 0.5 milligrams of colchicine, which is a very small dose, which does not produce any side effects, or a matching placebo, over and above whatever you want to give, depending upon the population. And the primary endpoint was a composite of cardiovascular death, spontaneous or non-procedural MI, ischemic stroke, or ischemia-driven coronary revascularization. And the key secondary endpoint of composite of cardiovascular death or spontaneous myocardial infarction. Patient population large, more than 2,500 patients in each groups, average age 65 years, diabetics about 18% of them are diabetics, and they are on equivalent number of drugs, single, dual, anticoagulant, means absolutely matched patient population. Here you see, colchicine, if you give in this small dose, the primary endpoint of a composite of cardiovascular death, non-procedural MI, or ischemia-driven coronary revascularization, significantly lower, about 31% lower. What a startling and a good effect by just using a simple drug. Secondary endpoint, a composite of cardiovascular death, Spontaneous myocardial infarction, significantly lower. Key endpoints, whether you use any way you look at it, it is beneficial as compared to the placebo. And non-cardiovascular death, diagnosis of cancer, anything, it has not given you any problem. So in this randomized trial involving patients with chronic coronary disease, the risk of cardiovascular events was significantly lower in the group of patients who received 0.5 milligrams of colchicine once a day than among those who received placebo. You give everything, but add colchicine in this small particular dose, and you are benefited. CANTOS trial was a very important trial in which a very expensive agent was given, which had first shown that an anti-inflammatory agent is very useful, and this is a very low cost, low dose anti-inflammatory agent. Coming to other important trial, we know that lower the blood pressure in hypertensives, better the outcome. But most of the trials are in relatively younger people, less than 60 years of age. This is a Chinese trial in which older patients have been included, because this answer is yet to be given. Multicenter trial, patients of 60 to 80 years of age were intensive BP control. That means you keep the blood pressure close to 110, less than 130, versus usual, keep it around 140, 90 or lower than that, and see the difference. The primary outcome is a composite of stroke, acute coronary syndrome, acute decompensated heart failure, coronary revascularization, atrial fibrillation, or death from cardiovascular failure. These are the things which usually happen to hypertensives, especially elderly. Again, 4,000 plus patients recruited in both the arms. That means around 9,000 patients have been taken. And you can see they are all, average age is 66, 46% are males, 25 is the BMI, systolic blood pressure, as you can see, average is reasonable, 146, 146, that means they're reasonably controlled pressure, but in one arm, you're going and reducing it substantially. Their lipid levels, their HDL levels, their diabetic status is equivalent. That means there's no other variable which is different. And here you see, intensive treatment, within few months, you're seeing a significant difference favoring the intensive therapy in these relatively older people. Strokes lower, acute coronary syndrome lower, acute decompensated heart failure lower, atrial fibrillation is almost the same, death from any cause not very different, but all these things are significantly lower. Cumulative incidence, you again see that it happens, the curves start diverging very early. Very safe, no dizziness, no syncope, no reduction in eGFR. Some people believe if you reduce the BP markedly, their creatinine will start going. Did not happen. So conclusion is that in older patients with hypertension, intensive treatment with a systolic blood pressure target to 110 rather than 130, 140 is better. Coming to, I think the last trial which I'm going to discuss is the Tom Hawk study, which again, here is the patient. We know that patients who have out of hospital cardiac arrest with ST elevation MI must be treated straight away, taken to cath lab. But we're talking here of patients who had a out of hospital cardiac arrest, are brought to the casualty or emergency, resuscitated, but no ECG or enzyme evidence of myocardial infarction. The benefits of early coronary angiography versus usual therapy, that is to be done, because we still believe that if a patient has had a cardiac arrest, whether MI or not, take him, the patient, to the cath labs. This is a trial which is answering this question, that patients who do not have a MI, what do you do to them? They're successfully out of hospital resuscitated, no MI, immediate angiography, versus delayed or selective. You may not even do it if you find non-invasive investigation is not required. The primary endpoint was death from any cause at 30 days, and secondary endpoint included a composite of death from any cause or neurological deficit at 30 days. Once again, there are patients more than 69, 70 years of age. 70% are males. Coronary angiography in the immediate angiography is performed in 96%. In the delayed one, in only 62% of patients. Median time from arrest to angiography in the immediate angiography is within 2 to 3 hours, whereas here, whatever is done has been done at 46 hours. That means, 2, 3, 4 days later. And, no substantial disease found in about 1/3 of them, and various degrees of single, double vessel disease. Angioplasty performed in 37% here and 43% in delayed. And once again, you can see that the hazard ratio, delayed or selective angiography, if at all, is showing better results than immediate angiography in this group of patients who had no evidence of a myocardial infarction but had a cardiac arrest. And you can see that immediate angiography is better in none of the subgroups, whether you go by age, diabetes, male, female, or anything. So the trial concludes that among patients with resuscitated out-of-hospital cardiac arrest without ST elevation MI, the strategy of performing immediate angiography provided no benefit over a delayed or selective strategy with respect to 30 days risk of death or any cause. It has some limitations of the trial design. The patient with hemodynamic or electrical instability or cardiac arrest had been excluded. But taking an overall impression, it suggests that one doesn't have to rush to the cath lab in patients who had presented as a cardiac arrest but had no MI. So let me give you some take-home messages of what we talked about today. Number one, heart failure with preserved ejection fraction for the first time has shown benefit of a drug convincingly, and that is Emperor reduced 10 milligram per day of empagliflozin over and above management has significantly reduced the hospitalization, which was one of the very important endpoints. Low dose aspirin is equivalent to 325 milligrams for prophylaxis of chronic coronary artery disease. Clopidogrel for long-term therapy as a single antiplatelet therapy after PCI is superior in reducing vascular events and has lower bleeding. Chlorthalidone in patients with stage 3 and stage 4 chronic kidney disease, where the eGFRs are very low and BP control is not satisfactory. That is resistant hypertension. Over and above, if you give chlorthalidone in a dose of average of 25 milligrams, there's a significant benefit in reduction in blood pressure. After ST elevation MI in multivessel disease, after culprit vessel angioplasty, FFR has no advantage over conventional angiography. Low dose colchicine, 0.5 milligram, reduces cardiovascular events in patients with chronic stable coronary artery disease. In elderly patients with hypertension, intensive BP control as compared to standard guideline therapy reduces strokes, MIs, ACS needing hospitalization and need for PCI and acute decompensated heart failure significantly. And finally, immediate invasive evaluation in patients with out-of-hospital cardiac arrest without ST elevation MI provides no benefit over delayed or selective strategy. Thank you very much. Thank you for your patience.
Thank you, Dr. Kaul. I think it was a very nice presentation and you covered all the new trials with nice take-home messages. Basically, sir, whenever we talk about a primary prevention or a secondary prevention, or primary prevention, we are talking that aspirin as such doesn't play a role nowadays or because of its gastrointestinal side effects. But for secondary prevention, it's a low dose is still preferable. And one trial which you mentioned was about the CRF and the role of chlorthalidone in a resistant hypertension. I think that was really a good message, because whenever we say in CKD patients, the chlorthalidone or thiazide diuretics we don't use, because we are using a more of a Lasix or Ditor. Those are the
Yeah.
drugs which we use in renal failure patients. Again, the dual antiplatelet agent, because in India we have a practice that the combination drug, triple drug is available, and that's why many people continuing the dual antiplatelet beyond the 1 year. And actually, if we look at the trials now, they talk that after 1 year it should be a monotherapy, which is a helpful, and it really prevents the events what we want to prevent. So what is your say, sir, about the this aspirin for primary prevention, and in the CKD trial which you said, in those patients their diuretic in a furosemide, or that was continued or not?
Everything was continued in the chlorthalidone trial. Everything was continued. All of them are on, loop diuretics. All of them are. And in spite of that, all of them are on calcium blockers, but yet their hypertension was not coming under control. At that stage, while continuing everything else, they just added chlorthalidone, which none of us does it. We think that thiazides are useless in this group of what will a weak thiazide do? Here it shows that this weak thiazide, but chlorthalidone, not chlorthiazide, because chlorthalidone is more potent, longer action. It does work. And I think this is a very important message. Primary prevention and aspirin has been long been given up. We know that overall benefit, if at all there is some, is counterbalanced by bleeding. So it has been out of all the guidelines, even in diabetic patients. We thought that, okay, diabetes means that something like they already have a silent vascular disease, so give aspirin. Even in that group of patients, it did not. Even in the very elderly people, where we thought one aspirin a day keeps a doctor away in those elderly people. No, it doesn't. In fact, they bleed more. So for primary prevention, no aspirin. And this was a very important trial, the trial of clopidogrel. That means in long term, we all continue with aspirin. Although in some patients now we combine rivaroxaban 2.5 twice a day after, the trial, COMPASS trial. But long term, clopidogrel versus aspirin, this Korean group has shown, is much better. It reduces vascular events more than aspirin. It reduces bleeding. So I think this one can keep in mind before you are adding, because every patient does not receive rivaroxaban. There are only patients with more than 2 vessel territories, patients with heart failure, patients with chronic kidney disease. There you add rivaroxaban. But others, there is a suggestion that if you continue clopidogrel instead of aspirin, that might be better.
And about the elderly patients, the trial, Chinese trial, which you talked about.
Hypertension. This
Yeah,
again
hypertension.
is very important.
Yeah, hypertension.
Very important.
Basically, it's a very encouraging results. And in practice, actually, about elderly patients, we talk about the postural hypertension and developing other complications. We are trying to keep a BP at around 130 or 140 also, so that the patients will not have problems. But this trial is really encouraging that the strict control of the systolic blood pressure really helps in controlling the events in the next 3 to 5 years.
Absolutely. So, very early. The benefit starts very early. Yes, within months.
That's really a nice trial, I think.
And that is the patient population who has a high risk, elderly people with hypertension.
Yeah. Vinod?
So that was really very enlightening. And let me tell the whole audience that when we know Professor Upendhra Kaul, I made a mention that he's the father of clinical research and trial in India. More than 2 decades back, when I had a very critical patient with stroke, renal failure, heart failure, and we had taken him to Batra Hospital for rotablation. And we were even doing the cold laser study. And he had a perforation, and the patient, miraculously, we could get out. So when sir presented that in our CSI journal, besides Delhi, he mentioned even the NASHIK hospital. So he's associated with us with the STEP study with semaglutide and many of the important studies, whether it be ziltivekimab or pilacarsen, inclisiran, and even finerenone. with which we are conducting, we have his blessings and continues to guide us. So only thing was, I wanted to know that I felt that Cantor study was a very promising study which reduced. Was it some industry bias that it was withdrawn? Because now we are again talking of ziltivekimab also, which is again going to work the same way, or maybe colchicine. These are going to be drugs of future.
Colchicine versus, the more expensive anti-inflammatory agents has the advantage is easily available and its side effects are very low. Other drugs, like the drug in Cantos, was very, very expensive and it produced pulmonary tuberculosis and some infections and systemic things. So it never came up. It never came up. But, it's very promising, this trial with colchicine. And I think it's a very strong motivation for using 0.5 milligram of colchicine. Kya jata hai? 0.5 milligram colchicine dal do yaar.
Any questions? We have got a record audience of a small society of 42 people had logged in. And any questions we will encourage from the audience, though an oration is not supposed to be followed by question answer. But then here with sir around, and we thought we'll go beyond before we start with our very brief installation. Yes, anyone there, please highlight yourself, demute or
Yes, sir.
Good evening, sir.
Good
Yes,
evening.
Rajendra.
Yeah, Rajendra.
Sir, all the trials, whenever we discuss, aspirin is either 50 mg or 81 mg. So, but we, all of us, we know we use it 75 mg. So, is it like okay to use 75 mg? Sometimes we end up in using 150 milligram of aspirin.
I think 75 and 81 is not very different because in America it's 81, which is Bayer makes 81. So I think we're quite justified in using 75, and I think what we have been practicing is fine.
Okay, sir. Yes. Sir.
for a body mass index, 75 may be a little more suited or equivalent to 81.
So,
Good
shall we
evening, sir.
say like all cases we should just use 75 mg?
Yeah, 150 has no role. Additional advantage, no additional advantage.
And I
Okay,
think
thank
with
you, sir.
ticagrelor or 75 mg aspirin is only recommended with all new trials.
Yeah.
Only with
Same with
clopidogrel or the prasugrel we are using aspirin 150 mg. Yes, Atul, your question.
Yes, good evening, sir.
Good
Yeah.
evening.
So, excellent insight from your side. And I think the thought process has been changing, as you say, using anti-inflammatory in chronic stable angina or rivaroxaban in chronic stable angina. Are we looking beyond the only pathway of platelet inhibition? We are going more towards the prevention of or preventing clot formation. So do you think these drugs will be more and more used nowadays? Especially rivaroxaban, we have been especially promising results from COMPASS. The use has definitely increased.
Yeah, I think clearly the COMPASS study, which addresses long-term vascular event reduction in selected patient population, like patients with multivessel disease, patients with impaired renal function, patients with heart failure, it's very clearly seen that aspirin 75, low-dose aspirin, along with the smallest dose of rivaroxaban, 2.5 twice a day, long-term, is very useful. It reduces, it improves the mortality. First time it has shown that it is reduces the all-cause mortality. It does increase bleeding, but it does not increase intracranial bleeds. It does not increase fatal bleeds. We should be very little careful about the bleeds, but then it's not those fatal bleeds which are increasing. And I think it has come as a guideline that a dual therapy, aspirin, along with anticoagulant.
Yeah, taking care of both the pathways, not only platelet, but the clot formation
absolutely.
also.
And it is clearly better than continuing aspirin with the ticagrelor, which many Pegasus study has shown that go to 60 milligram twice a day of ticagrelor with aspirin, which has not shown any mortality benefit, some benefit, but this has shown mortality benefit. It's clearly better than Pegasus COMPASS results.
So one question,
you.
in case you have a patient who has got bleeding, even with 75 milligram, and then just, I mean, there is no comparison, but in the COMPASS study, And would you like to give clopidogrel or even after 1 year low dose clopidogrel along with 2.5 of rivaroxaban? Though there are no studies to prove.
There's no big study, but that is what most of the people believe, that if you can't tolerate aspirin, clopidogrel. In this study, which is comparing aspirin with clopidogrel, has shown that it was better than aspirin. In bleeding also, it was lower. So no doubts. Although in COMPASS, they used aspirin, which is the commonest used antiplatelet agent throughout the world. But I'm sure you can use clopidogrel.
Sir, about the ST elevation myocardial infarct, non-culprit vessel, you said that KFFR doesn't play a much important role. And what should be the timing for the non-culprit vessel angioplasty? Means if the patient is not having a shock or LVF, usually we defer for 2-3 days. So what do you do in your practice?
It all depends upon, if your result of the culprit vessel is excellent and the other vessels which have significant disease are simple. They're not requiring a rotablator or they're not requiring a bifurcation angioplasty. In that situation, you could do it in the same day, same go, especially if you're during the day with your full team. If you're doing it middle of the night at 2 o'clock in the morning, at that time, now let us go to Remus and let's go to right. Probably that's not the best time. But simple lesions, you can straight away do. But complex lesions is better to do. And also depends upon the result of your primary angioplasty. If you're very happy about that, then only you think about these things. And if you have done it within the first few hours, you have not not done it in a patient with the ejection fraction which has already become 35%, and now you're trying second vessel, and if there is even a small MI by a loss of a branch, you're going to get into problems. So individualized, but it is possible.
Yes. Okay.
One question from my side. I'm a cardiac surgeon. I'll identify myself, sir. Good
Yes,
evening.
sir.
Sorry for joining late because there was a little discrepancy for the time. Catching Manoj Chopra's the question further, FFR over eyeballing the lesion. Now you are saying that FFR has no significant advantage.
In that flower MI study, yes.
Yes, it doesn't have an advantage. Now looking at the purview with the number of young cardiologists coming in, and they're having a confusion of targeting the 70% lesion. And as you say, it's a simple lollipop lesion and you can just put a stent there. For the surgeons, younger ones, what would you think that should they go for an FFR at that point, or should they just leave that lesion and probably do it at a later stage? Just from the point of view.
There are two ways of doing it. If it is a really, you think the other lesions are, 50% kind or something like that, the primary lesion you have done, I think you just better leave it that time. Okay. But if you think, the other lesion is significant, eccentric but significant, the study has shown that doing an FFR is not going to do any advantage over it. So that is what the study has shown, and some previous studies have also shown this. But as the editorial has said, that if that is the answer, this is very good because it's a cost-effective way of doing it. And some people like Bernie Meyer and others always say that what the hell, if there's a 60% lesion, 70% lesion, why not fix it? So, it's what you want to do at that stage, but science would say that go for a significant lesion. The study shows that angiographically significant lesion, whether you do a QCA in that, measure it, ask your colleague also to have a look. If both of you think that it is significant, then additional FFR is not helping.
Okay, fine. Thank you so much for your answers.
Vinod, anything else?
Yes, Suresh Suryavanshi has raised his hand.
Yes, sir. Good evening, sir. Thank you very much for enlightening us on the updates of this during this oration. Now, sir, the question is regarding the hypertension control in elderly. So we had a sprint trial and which helped in a reduction in the target goal of the systolic blood pressure to around 120, 125, which we used to consider 135, 140 previously. Then post sprint, the European Society has again raised the BP goals to 130 to 140. A too stricter BP control is not allowed. And now again, this trial, which is allowing us to go down the systolic blood pressure in elderly up to 110 milligram,
Yeah,
millimeters
less than
of mercury.
130.
Lesser
Less
than
than
130.
130.
So now again, there is this is a single trial. Now we are again in a confusion. Like a sprint, we used to control it more. If the patient, obviously the patient, if patient do not have a side effects and all, and if they are tolerating, lower is better.
They
But
have excluded patients with a stroke. That's the only thing. They have excluded patients with a previous stroke.
yeah,
And in that particular patient with elderly, they've shown that benefits are remarkable and start early. And so it's an extension of sprint trial in elderly people. Sprint had excluded elderly.
okay. So probably down the line, we are coming with a stricter BP control trial,
That's right.
BP goals. And
Lower the better in
lower
BP,
the-
at least in BP. Yes.
Sir,
Also in
one small,
cholesterol. Yes.
one
Thank you,
small
sir.
doubt.
Thanks a lot.
I always feel, I think most of you will agree, whenever the targets are brought down, they are always market driven. Sugars, you need to be 100 millimeters of mercury, normal sugar. How often do you, say 100 fasting is normal instead of 126? So the goals, when they bring down to say 100 sugar or BP 120, the population, target population increases. And we see they come back with orthostatic hypotension, sudden falls in elderly people. It's very common. So is it really practically advisable from personal perspective?
Well, this particular trial was not a pharma sponsored trial. This was sponsored by the Chinese Heart Association. And in general, it is showing that going to lower blood pressure is better than leaving it the standard listing, indicating that obviously patient has to be individualized. If a patient by 110 pressure is getting giddy and all that, obviously you will not do it. A patient who is tolerating it and the pressure is lower, the trial has shown that don't worry, it is going to have better outcome. What's this elderly population, you are scared of strokes, you're scared of MIs, you're scared of heart failure. So this everything is being reduced modestly but significantly.
Thank you.
Any further questions? Yeah, please. I think the individualization of treatment is going to be very important.
Always.
All situations. It's
Don't go by the conclusion of a trial.
Yes.
Go,
Those are the guidelines for us.
keep it in the mind.
Yes.
And when you're treating the patient, every patient is different.
Yes.
And they say a trial is not law. And
Yeah.
I mean, in fact, and you have to see as long as the patient tolerates is important.
Yes.
So any further questions?
No, I think.
As far as extended, in fact, he had a further engagement after this, but I'm really thankful. And sir, with your permission, we'll be editing, modifying and putting it on our website. So
Okay.
would
Good.
you give us the permission to do so?
Yeah, of course.
So thank
Go
you
ahead.
very much for that. And I would suggest we are just having a very brief installation because there are no drink and dinner. So probably it's going to be brief. So we will just start, and then with a senior person like you can say Tatastu. That means it is done.
Okay.
So we start. So we had started as it was first proposed by Dr. Manoj Chopra and Dr. Anirudh, that we formed the society, and that was on 10th of Jan. So tomorrow 1 year. It took us almost 1 year to get the charity trust and everything. So how difficult it was because of the COVID situation. And then we had volunteered for those who had come. And so I take over the responsibility as the president and would pledge to work for the betterment of the society and bring up the status and the respect in the society. And once we give over, and I suppose it will not be digital, probably I promise you it will be handed over in a cruise meeting, and we will invite Dr. Upendhra Kaul to join us in that cruise. And I suppose that, and
with red wine from NASHIK.
Yes, and yes, sir. And then also is Dr. Kochar there? He is the vice president of the society. Dr. Kochar, please, can we focus on him? And we have then Dr. Ashutosh Aher. He is the treasurer of the society. Dr. Kochar is a cardiac surgeon. Dr. Ashutosh Iyer is a peripheral vascular surgeon. Because he is the treasurer and they say cardiologists have a lot of money, so we have taken his passport. He doesn't disappear. We have Dr. Kunal Desai, who's the endovascular surgeon. We have Dr. If they are there, you can please highlight them on the photographs. And then we have Dr. Nilesh Purkar, who had volunteered. He is a surgeon. Dr. Kunal Desai, as I mentioned, he is endovascular specialist radiologist. And then we have Dr. Anand Parekh, cardiologist among us, who is also in the group. And hi, Kunal. Nice to see you. Anything
Hi, sir.
you'd like to mention?
Good evening.
And then, of course, Dr. Vikrant, who is the secretary of the society. So we will all be there. Though, of course, this is just technically for people who have undertaken to work. But all of us are equal, and we would continue in the same way. So if there are any further, are we installed? So we declare that our society is born from a fetus. We are a newborn or neonate in the presence of such a senior cardiologist among us, a Padmashri. We are all proud, sir, that you have
All the best. All the best.
And we will remember
Wish you
to
all the best. Wish you all the success, many, many years to come.
Yes, sir.
And may the society grow with leaps and bounds.
And we continue to get your blessings. And now I would request who's going to present the vote of thanks. Vikrant? Yes, when we conclude.
Good evening, everyone.
सर आपका स्पीकर और माइक दोनों बंद कर दीजिए क्योंकि एक ही जगह से होगा ना दोनों, इसके लिए।
Unmute yourself.
Every one of you to have volunteered to become a member by registering not just as a token, but by proactive participation. Would like to thank all the members of executive committee who have volunteered to remove their time from the very busy schedule and work for Cardiovascular Society. Very special thank to our pharma and industry associates who have promised all-out help for our academic and social activities. Notably, Shri Unatkat Milan, who is there with us today. In fact, he has been, just to conduct this meeting, which was actually to be held in Radisson. Initially, we had chosen 2 sites, and finally, we decided on this date in this hotel, but because of COVID, it was not possible. But though the date is postponed, but the meeting is still going to happen whenever the world starts again. And earlier with Sun Pharma, I would request all of you to use your good offices to conduct meeting via Cardiovascular Society only. Shri Sudham Pendare, I would request him to come here, please. So Sudham is here with us. Most of us know him. In fact, I have already worked with him for 3 years when I was a joint secretary of API. And oh my, when COVID actually came, it was so difficult to coordinate things, but he has always been there beside us. Would like to thank him for his timely help without even asking for any remuneration. He also works for API, MMC affiliation, maintaining all the records, website, charity commission. In fact, our charity commission, it happened in 30 minutes. We got the certificate thanks to him. Also, the hotel and staff of Radisson Blu for promising to keep this meeting on hold. Ultimately, we would host the meeting once things and times are better over there.
So, yeah, in fact, he could not thank himself because he is the unpaid employee and he has to work because he has no choice. He has to follow his father's orders. Same thing we had done with API and now again with Cardiovascular Society with his time and money. But with that, it was really a wonderful evening. Again, I apologize that we could not make it physical for you all know. And I would call this meeting to a close, but we can even continue the chit chat beyond the meeting. So the official meeting is over and there are many people who have just entered the room now. So good, that's nice. And is Dr. Praveen Jadhav there? Today is his birthday. I had shown him a digital cake. We'll try to cut it. Praveen Jadhav. Good to know that we are still 37, 40 people are here. The official meeting is ended. So, and we can have a chit chat till we all sign off.
He probably is opening a champagne somewhere right now. So happy birthday to him.
Happy birthday. Yeah. One of our members today.
So lot of credit. I mean, the credit goes to you for taking efforts and spending so much time for the formation of society, going to the charity commissioner and doing the formalities. So at this age also, you are being so active and taking efforts. So we are really happy and we are thankful to you. Otherwise, I think it would not have happened. The official organization, it takes a lot of commitment and you have done it. It's really a commendable job. Another thing is, yes, sir.
The only suggestion to this, of course, my age, I mean, we were class fellows in the same class. Now, when you, I mean.
We both of us.
So,
yes, sir.
See, we all have our own groups. The pharma, you are all very prominent people. And all pharma companies are in line to help you out. So we can have our own small cocoon meeting which people have. That besides the point. But encourage them whenever they come. Now you have to register. And then just like in API. See, I was the API president for 3 years. And then we really, in spite of the COVID, we could yet build up some bank balance because we used to tell them to pay a small token amount, which was necessary for the running and smooth functioning. And we enjoyed those 3 years, even though I was in exile in US when the lockdown occurred, unfortunately. So same thing, please, any meeting that comes to you, always tell them that come to our cardiovascular and
that's what I was coming to it, sir. That's what I was about to say, that we should start this as a regular activity rather than, once in a while. So let's make it say that every month, one specific day or date, we can say that on this day, we will have this meeting. So, back of the mind, at least majority of us can say that, okay, on 2nd of this month, there will be a cardiovascular meeting or 4th Saturday or Sunday, something like that. You can come up, in the meeting. So we keep our day free on that particular day, evening. So now COVID being on a higher side, we can start digitally and later on that same thing can be continued with the physical meeting. So let us decide one particular day of every month and continue this activity. That is how we can, improve our academics as well as discuss the cases and our work.
Yeah, we would certainly, I mean, have a consensus and then fix up the day for a clinical meetings like which we had. And then we should have, workshops also, I believe, which would be there in interventions, workshops, even on the surgical side. We have our endovascular specialists. They are doing remarkable job. They will come and present. It doesn't mean, though maybe 80-90% of us are probably cardiologists, but then we have got cardiac surgeons. They are doing exemplary job. They can also keep the presentation, and we'll encourage. These are all the 4 pillars. As I said, I'm very sure. I don't think there is any society which has all these 4. Now there was a question: can we expand this society? Can we take cardiac anesthesiologists? So I said, till we form. Now we are formed just today, but we are, and all those who have registered, they are the ones who will participate in voting, because this is what, as per the charity commissioner clauses and all. So they are a little strict. So then if you want to take any further decision, like I wanted few more things, can we take any person as an associate? Just like in our CSI, he may be a physician or he may be a general surgeon who may want to be an associate but not participate, but yet can pay certain amount, So that the general body can only is empowered. We as an executive do not have the powers to decide. Same thing about cardiac anesthesiologist, and maybe someone say, like some electrophysiology person, and then we may have a person who may not be DM or DNB, may want to join SNS. So this will be a little long list, but in the long term, it is always good. And then we should have one grand CME every year. That should be. It should be like a refresher course or like a conference, which will present all our data and encourage all presentation research. I'm sure we will all rhyme together. And one or two functions with the family. You should come with your spouses, with your better half, so that all the family members gel with each other. And we are like a family. This is what it is, beyond just academics and meeting. This is what, that's why we had gone to Rakabi the firm, but the place was not developed, and many people said because of COVID they will not be able to come. Even today, we had even thought that today we could not have the meeting. Let us give dinner boxes to all those who have attended. But again, people said that they will not like food handlers. So many things have come in between. We plan many things, but unfortunately things happen the other way around. But we are very hopeful. And it is only, look at the enthusiasm we all have shown. Commendable, I should say. And each one is equal. Please come, even criticize us also. And other thing is, I thought that instead of, again, we are not empowered, it will be only in GBM, that we should have just like CSI and other and incoming. So at the end of 1 year, let the new incoming president come. And then he follows he sees the pattern. And then when we hand over, hopefully in Cordelia, and when we complete our term, so that person is already taken over. I mean, these are few thoughts and suggestions, but that only the GBM is empowered.
Again, the Malegaon, Dhulia, Jalgaon, what we were talking about, taking them together with us, that can be done. Means those can be added. Basically, we thought of North Maharashtra Society.
We have
started with the NASIK. So I think those cardiologists also can be added to this group.
I think we should have
already part of this is Cardiovascular Society of Nasik district. See, if you see the map behind, it is actually, no one can copy this because it is a map of Nasik district. So even if you copy it,
I'm talking about the other districts also, Dhulia, Malaya.
North Maharashtra, we had already thought of. And and you remember, we were trying to form the Cardiology Society, and I've shown enough letters. Even till today, I've talked with Vijay Bang, who's our colleague, and he's the incoming president. Even still, they have decided not to form. They are trying to form a Bombay chapter. It is not possible.
Basically, but the cardiovascular CSI Bombay and Pune chapter is already there, I think.
Those who are there, they cannot dissolve. Vidarbha chapter is there. Pune chapter is there.
That's why the rest of Maharashtra chapter we can increase through this society.
Yeah, they can. And then it is good. See, today we are unique that it is beyond just cardiologists. The peripheral vascular surgeons, the interventional cardiologists, maybe even the cardiac anesthesiologists can come that way.
I personally feel that we should at this moment restrict it to the cardiology and cardiothoracic surgeon and interventional radiology and all, and we can let people from Dhule and Jalgaon and North Maharashtra to get associated. Physician and all those things will not as an associate member at this moment, at 2-3 years probably. We will just gel with us each other, conduct a monthly good academic meet where good academic presentation which goes on in Pune or Hyderabad, we should have those type of things. 6 monthly, some small get together kind of thing, once or twice a year, and a national conference or a yearly annual conference. We can have a good conference there. And it will work very nicely. We got a lot of people. We got a pediatric cardiologist, we got interventional radiologist, neurologist, and peripheral vascular surgeon, a cardiologist. So a lot of, and I request most of the people to register their cases who are supposed to present those to the secretary or the other executive committee member. They can line up the cases, and for a monthly meeting, as Dr. Rajendra has suggested, we can plan one of the day which is fixed. So once the day is fixed, everybody in the mind, 2-3 meetings we can plan online right now, from next month. And then if you got a nicely those cases lined up, I'm sure that most of us have got a good cases where we can have a good lessons to be learned. And we can line up those cases 2-3 cases a month, and then we can have 4-5 months lined up things, and that will be good. And in every 3 months or 4 months, we can have some national international speakers who can enlighten us on a very hot topics or something like that. Yeah, I think that can be planned from next month.
Very correct. Very correct. Milan, since you have been helping us with this, if you have something to say, or maybe 1-minute presentation, because you said that let us keep it non-academic, but you are also responsible to, as I said, pharma and the strength and industry are our supporters, and we have to give them due respect. You have even shown us a digital lamp lighting, and I think, are you going to show digitally open some champagne or something?
I think, sir, I would like to serve it the real champagne. So
that's for you, actually.
Yeah. So as soon as
it.
the COVID permits, I stand by my commitment that we will have that gala night. The situation, once it gets corrected, we will have the gala night, which I have promised to all of you, and we'll go ahead with our the mega event which we have already planned. I would like to appreciate Dr. Vijan that the kind of enthusiasm he has shown and the time he has taken out from his busy schedule to plan this entire event. Every minor detail he has planned, and everything was worked out. Unfortunately, the last week there was a sudden outbreak of COVID, and we had to move from physical mega event to a digital event, which is even everybody was ensured to attend a meeting. So I really appreciate you, sir, and thank you for this opportunity. And I stand by my promise that as soon as the situation permits, we will take it to physical and conduct a mega event with the academia and the fun part, both balanced together.
And we also have a website for everyone to know. So this recording, we'll trim it out and put it on the website. Do I have the permission from everyone? Dr. Kaul has already given his consent for his lecture.
Yes,
yeah, sure. Okay, then we sign off. Have a nice time. Open the real bottles now. Digital to abhi nahi hai inke paas. And then we meet again. Thank you, everybody, for making it possible. I would say it's a great success considering the circumstances.
Yes.
Thanks
And
to
sir,
you.
all future events, if you like any kind of sponsorship from our side, as a JB Chemical, we are always committed to provide academic platform. And in this open forum, I say that I will be always available to provide the academic support from my organization at any point of time in future events. We have formed such societies in nephrology at various cities, and we are supporting them throughout the year. So you have one-stop solution to all these problems if you look forward for that. So we are always ready to provide that platform wherever needed, sir, physical or digital, in either way.
No, we'll prepare physical, and Cordelia.
Yeah. So I'll be ready to conduct. I mean, in the frequency you decide in the general body meeting, and we'll be there to get associated, and we'll consider ourselves fortunate to get the opportunity in future also. Thank you, sir.
Another thing, may I mention, when he came last time to meet, when he returned back and he turned out to be positive, and he's still in sort of quarantine, but yet look at his enthusiasm. I mean, let me 3 cheers and all of us. Yeah.
Thank you, sir.
Thank you, sir.
Bye then, we all sign off. Have a nice time. Be safe, friends. Let us be in touch with each other. Bye then.
Thank you.
Congratulations.
Thank you.
Yeah.
Thank you.
One person has just entered this thing. Just tell goodbye to him. It's never too late. Bye. Take care. Yeah.